Health Disparities in the Delta, presented by Hannah Lakey, Sarah Talley, and Hannah McCoy. A major problem that has and is still contributing to health disparity among women in the Delta is food insecurity. Food insecurity continues to cause a major health crisis in the Arkansas Delta. First, Dr. Charles Field, a retired UAMS faculty member and an Arkansas medical historian, gives us a brief history of food insecurity in the Delta.
In Arkansas, we have a very good source of that type of information from the Cedar Grove Project. Cedar Grove was a church, and due to a flooding control project, there was a cemetery with bodies from 1890 to 1927 that had to be moved. With some very sensitive and delicate negotiation with that local community and the congregation, they agreed before the remains were reinterred to be able to do testing primarily for underlying health issues, and we have that data available. It showed deficiencies in just about everything that you can name and evidence of subsequent diseases from that. Pellagra, which is caused from taking the tryptophan out of corn. Scurvy, which is a vitamin C deficiency that many fruits and vegetables contain that is unheard of now. Vitamin D deficiency, which led to, along with the calcium deficiency in their diet, with almost no dairy, led to bone abnormalities, brittle bones, very early aging of osteoporosis and osteoarthritis. That, combined with the very heavy workload compared to studies that had been done on enslaved people prior to the Civil War, showed basically no change in health that had occurred 30 years to 50 years after the Civil War. Many people that were sharecroppers or tenant farmers had very limited space to grow crops. Much of that was done with corn, which would be converted into cornmeal, which was a major carbohydrate source, starch. The issue for many infants was they were breastfed until about 18 months, and then when they were weaned, they developed a disorder that's not seen now called weaning diarrhea, which is a fairly complex and still not well understood response of the gastrointestinal tract to switching from breast milk to a mixed diet. That, along with the absence of calcium and vitamin D, started problems with bone development and short stature that continued on into the 50s and 60s. The scurvy led to poor healing and abnormal healing in bones, that until probably the 1920s. During the 1920s and early 1930s, there was very poor nutrition in Arkansas due to the Depression, due to the collapse in agriculture prices that had happened a decade before the Depression, and the 1927 Mississippi flood, which disrupted not just cropland, but killed most of the livestock and made the infrastructure for transportation for food and food delivery unavailable for months and months and months. The Red Cross came into South Arkansas, actually with the opposition of the state government and the federal government, who worried that feeding hungry people would lead to more laziness, quote unquote, and to dependence on handouts and on charity and on welfare. Things got so bad that when a Red Cross warehouse in England, Arkansas, which is 30 miles from Little Rock, ran out of food, there was literally what was referred to as a riot, but in retrospect was desperation, and local stores were broken into and foodstuffs were taken home to feed a hungry family. When the draft began in 1940, were found to be ineligible for the draft because of multiple medical problems, and many of those were included in nutrition. Short stature, vision problems, joint disease, and underweight. This was not a huge surprise to some in the military because military leaders, especially General George Marshall, who was the architect of the Allies' victory in Europe, had worked with the Civilian Conservation Corps during the Depression, bringing young men from poor areas and poor families in to provide them a job skills, an income, but along with that, health care and nutrition. And they were aware of the very poor state of health, particularly in the South and in Appalachia and places like that, that were multi-generational poverty. End of World War II brought a lot of changes. It increased the middle class with the GI Bill. It increased expectations in minority communities who had served with honor during the war and were expecting to be served by the post-war boom the same way, and then many found out that they were not. The economy changed into higher tech and more of a service economy and made social mobility more difficult. At the same time, the grocery business was moving more towards prepared foods and away from fresh foods and vegetables, which frankly for a long time were seen as food for poor people, rather than being able to go to the grocery store at your convenience, pick up something frozen or canned, take it home, and you had a meal.
Today, specific components, such as the State Health Department and the Delta Regional Authority, help monitor the health of the Delta. Delta doctors, Delta Regional Community Health Systems, and innovative readiness training help with policies and plans for protection of the Delta. Enforcing laws and regulations, as well as making sure that there are plenty of doctors in underserved areas by providing scholarships, evaluating the health services through JCO and other accrediting bodies, as well as ongoing research like the Delta Garden Project, all add to the public health infrastructure. Access to care in the Delta is still lacking compared to other regions of Arkansas. Some counties in this region only have 174 healthcare providers per 10,000 people. That's roughly 58 people per every provider. It is important that we define provider. The 174 providers include those in 17 fields, including everything from doctor to licensed dental assistant. Lee County in the Delta does not have any pediatric or OB-GYN providers at all. Rural practice scholarship programs provide scholarships to doctors who guarantee to practice full-time primary care in the rural communities of Arkansas. With the lack of specialty providers, this includes those providers that assist with mental disorders. Most counties within the Delta only have an average of 0.2 psychologists per 10,000 people. There is a decreased quality of education for students. A report from the U of A Office for Education Policy made the statement that we may have enough teachers to fill the classrooms, but they are not necessarily teaching in their particular area of expertise. Many schools are able to fill their open positions, but they fill positions with teachers who actually specialize in a subject other than the position they filled. The Delta is a region of poverty. It was found that the areas that had the worst time filling open positions are those that are in the lower socioeconomic statuses. Political difficulties continue to grow for the region. The Affordable Care Act works to make health and care insurance more affordable by expanding the Medicaid program to cover all adults with income below 138% of the poverty level. It provides subsidies to those whose income falls between 100 and 400% of the federal poverty level. Continued efforts to repeal the Affordable Care Act threaten the increased coverage that has been offered to these rural communities of the Arkansas Delta. Arkansas is one of the leading states in health disparities. Arkansas's leading causes of death include heart disease, stroke, diabetes, influenza, and pneumonia. This disease states are often treatable and preventable. With 55 of the 75 counties in Arkansas being considered rural, this highlights the need for improved health care for these areas. 47% of heart attack victims die before emergency medical personnel arrive. Lack of emergency facilities in rural areas can have a major impact on high mortality rates due to a lack of access of care. The black male population also has a greater mortality rate than white males of heart disease. With the Delta having a higher percentage of minority population than the average for the rest of the state, there is a greater need to target this population. So what can we do as public health practitioners? With affordable and nutritional food options lacking for those in the Delta region, it is important to increase access to education on healthy choices. Whether the options for growing your own food or outreach programs that offer classes on healthy meal options, education on nutritional labels, plots of land reserved for community gardens or personal produce growth. Those with food insecurities can utilize community kitchens, local food pantries, and organizations like churches, community centers, local health departments, and other outreach groups. With a lack of healthcare providers for all specialties, it is important to increase access to care. Mobile mammogram units can increase access to women's health care. To increase health care for rural Arkansas, scholarships or student loan forgiveness can be offered to those who sign a contract to provide care to those in rural counties. An increase of health and wellness education programs for school-aged children through adulthood is vital for improving health outcomes. Increasing the amount of school-based nutrition and fitness programs to increase education on healthy lifestyle and encouraging increases in physical activity, as well as sexual and reproductive education to promote healthy sexual activities and preventable measures for pregnancy and STIs.